Thank you so much for joining us. I am Abby Ingber, the Executive Director of the National Education Alliance for Borderline Personality Disorder. We are a nonprofit organization that helps family members and loved ones who have someone in their life with emotional dysregulation or borderline personality disorder. We do this through advocacy efforts, outreach, awareness, education, and research. We are widely known for our successful Family Connections program. Family Connections is a 12-week free class led by trained family members and clinicians. The purpose of Family Connections is to provide psychoeducation, skills, and support to improve one's relationship with their loved ones who have BPD or emotion dysregulation. We offer Family Connections throughout the United States in person, also through Zoom and conference calls, and it is offered in 28 countries around the world. Due to the coronavirus, we had to cancel many of our in-person classes. We were very happy that many people were able to join our Zoom classes. We are offering these webinars for people who've signed up for an in-person class that had to be canceled, those on our wait list, and for our friends who may have taken the class but need a refresher. We will be doing many webinars over the next few weeks to discuss psychoeducation of BPD, emotion dysregulation, suicidality, and trauma, and also to teach skills. I know many of you forward your questions ahead of time to me. When we do open this up at the end for questions, you can also use the Q&A feature to ask questions. We most likely will not be able to get to all the questions today, but we will answer as many as we can. I also want to note that we are not able to diagnose your significant other with borderline personality disorder or emotion dysregulation. We will be talking in generalizations and talking about the characteristics without being able to diagnose your specific loved one. Beth is our presenter today, and I'm very pleased to introduce her. I will give a little introduction to her, and then I'll let her take it away. Beth has been very active in our organization, the National Education Alliance for Borderline Personality Disorder, for many years. She is on our board. She is one of our highly trained Family Connections leaders. She's our international liaison, our vice president of programs, and she really works tirelessly with our organization to provide all of you with so much love and support that is needed dealing with your loved ones who have BPD or emotion dysregulation. Beth, I will let you take it away.
Thank you, Abby. Well, welcome everyone, and I'm glad that you could join us. I'm especially grateful that we have the platform of Zoom to be able to reach out to you, and I think that we can accomplish a lot using Zoom. So I'm going to dive right into some of the content of what we're going to be talking about today, so that we'll hopefully have time for some questions at the end. So as you know, we're going to talk today about some psychoeducation about borderline personality disorder, to give you some background on the illness, and actually we spend quite a bit of time on that in Family Connections. Now, I'd first like to say something about why it's important to understand and learn as much as you can about the illness, and why we spend so much time on doing this. If the more that you learn, the more that you know about the illness, the greater your understanding is, the more that changes or can change feelings of anger or resentment that you may be holding, and turn that around so that you can engender more feelings of compassion. When you're able to look at things with a new frame of mind, or look at things really with a new lens, that allows you to be able to use some of the skills that we're going to be teaching you in some of the following webinars. So my own direct experience is that this is true. And the more that I learn and the more that I understand, the greater my ability to be compassionate and to use skills effectively. And that's the focus of this course, is to be able to be effective. So next slide, please. So first of all, I want to give you a little bit of background about the illness itself and some of the things that we know about it. We do know that BPD seems to run in families. And that doesn't mean that a person would inherit BPD as a full-blown disorder. That is not the case. But what appears to be true is that people can inherit traits or clusters of traits, such as mood, lability, or impulsivity, that might give them a certain vulnerability or predisposition to acquiring the illness in the right environment. So one way to think about that is that it's much like having a predisposition or vulnerability to some physical illnesses, and examples of that might be heart disease or high blood pressure that people might have a predisposition towards. Next slide. So one of the next things I want to talk about is just about the age of onset, or in this case, diagnosis of the illness. And one thing I want you to notice in particular is the high cluster of age of onset at early adulthood, ages around 18 to 25 at 50%. And even though, for many of us, myself included, we noticed differences or things that were happening in our families from a very early age. I'd like you to think a little bit about what happens when someone becomes 18 to 22. So in general, that's often the time that kids are finishing high school and starting college. And for people who struggle with emotion dysregulation, that's a time when some of the structures that have supported them start to fall away. And there's an increased call for independence and self-reliance, and that can be a very difficult time for them. And it's common for us to see things start to fall apart when young adults enter college or enter the workforce and are expected to be independent. Next slide. So the other thing that we know is that this is in fact a high-risk population. So roughly 65 to 70% of people with a diagnosis of BPD will make at least one suicide attempt. And we do often see families where there are sadly multiple suicide attempts. Up to about 10% of people with borderline personality disorder will actually die by suicide. About 75% of individuals with BPD engage in self-harm or self-injury. Now, one thing that's difficult, I think, for family members to understand and wrap their head around is that self-injury in borderline personality disorder is not necessarily suicidal, but in the absence of skills, it can be a way, a maladaptive way, or a means to regulate or bring down very intense emotions. So in this case, it actually can make them feel better. Next slide. So brain research is certainly in its infancy, but there are researchers that are seeing some differences in the way that certain areas of the brain function in people with borderline personality disorder relative to people who do not have the diagnosis. One thing I'd like you to understand is that people with borderline personality disorder can look at a set of faces. In this case, you see some of these faces here. They can look at a neutral face that's not conveying information that we might take in as negative, and yet see that neutral face as conveying negative emotion or negative feeling. So that makes it very difficult for them to read other people's emotions accurately. So Carla Sharp in Houston talks about this as hypermentalizing, or reading more into a facial expression than what is actually there. And you can imagine that that is very destabilizing for a person if you're not, if you're making errors about what another individual may or may not be thinking. The second thing, you can go back. Can you go back to that slide? Thanks. The second thing about brains that we know in certain areas of the brain is that all of us have an amygdala, which is a small section of our brain, our primitive fight or flight area of the brain, and that is very useful to us in situations in which we don't have time or shouldn't be thinking or reasoning out a reaction to something. So an example of that might be if I see a tiger come into the room, it's helpful that I have an amygdala, which is probably going to trigger me to run without spending time thinking about that. So in that situation, it's very useful to override my prefrontal cortex, which is the area of executive functioning, which would allow me to think through these things. So we also do have this area of our brain called the prefrontal cortex. And that area is responsible for executive functioning. It's responsible for planning and thinking things through before we just react in a big way, which our amygdala might have us do. So one thing that has been seen in research is that there appears to be less connectivity between the prefrontal cortex and the amygdala in people with borderline personality disorder. So people with borderline personality disorder, essentially, you could think of it in a way that they're walking around with a huge Ferrari engine of an amygdala and a small with small Prius brakes, right? So small brakes that aren't really effectively doing their job and dampening down those huge big surges of emotion. Next slide. So if you think about it in this way, you can imagine what it must be like to be experiencing that, both as an individual and also indirectly as family members. So people with this illness have high internal levels of anxiety and distress. High family stress related to that, obviously. And you know, even though these people are people with borderline personality disorder are often extremely intelligent, talented, creative, you know, have wonderful personalities in so many ways. Still, because of this handicap, emotional handicap, they have difficulty keeping jobs. To everyone else, they appear to be over emotional and impulsive. It's very common for them to abuse substances, alcohol, and drugs in order to try to relieve some of that intense emotion. And really, the hallmark of this is that people with borderline personality disorder have very stormy and fraught with difficulty interpersonal relationships. both in and outside of the family. Next slide. So even though that all sounds very grim, and I understand that, borderline personality disorder can be called a good prognosis diagnosis. And what that means is that recovery is possible and also even likely. So Dr. Mary Zanarini at Harvard has been following a large cohort of patients with borderline personality disorder for over 2 decades. And even before we had DBT. So what she found is that after about 2 years, more than 30% of patients recovered. After about 10 years, about 80% of her patients recovered. When recovery was attained, so when people dropped out of criteria for borderline personality disorder, that remission was strong. So about 88% of people who did recover remained in remission, which is high and hopeful. Another study has shown that about 80% of young adults with good treatment didn't meet BPD criteria within 2 years. It is important to understand that, for example, in Dr. Zanarini's cohort, about 40% of those patients were not able to work or go to school full time or have long-term partner relationships. So that is a good percentage of people who recovered, and at the same time, people who remained not as highly functional as one might hope. Next slide. So now let's spend some time on trying to understand the criteria for borderline personality disorder as listed in the DSM. There are 9 criteria for borderline personality disorder. In order to have a diagnosis, a person needs to meet 5 of these criteria. So one thing it's important to understand is that even if a person doesn't meet criteria, or a person might have 1 or 2 of these symptoms, that can still be very destabilizing and cause a lot of chaos in their relationships and in families. So the first criteria, and these are in general listed in frequency of occurrence. The first criteria is frantic efforts to avoid real or imagined abandonment. And that's important to understand that their perception is their reality. So that means that we may not have any intention of abandoning an individual, and at the same time, their perception might be that we are, or that we're thinking about doing that. And so it's not uncommon for people to see that someone with borderline personality disorder may be very upset about their loved ones or family members having other friends or engaging in activities without them, because they perceive it as possible abandonment. Number 2 is a pattern of unstable and intense interpersonal relationships. And what it means to alternate between extremes of idealization and devaluation is that so one day you may hear your loved one talking about an individual, and that this person is just the best person ever and such a wonderful friend, and there's nothing, there are no flaws in this person, and they're just the ideal human. And then that can very quickly change to the polar opposite. So the next day, you might hear that this same person is now a horrible individual and a terrible friend, and there's no interest in seeing that person again. And it's very extreme. It can be very much all or nothing in that way. The third symptom is a marked identity disturbance. And so what that really means is that it's people with borderline personality disorder may feel as if the floor really is shifting out from under them. They don't have a strong sense of their own identity, and they can often feel very much like outsiders. And that's a very difficult way to exist in the world. So they may seem to be very chameleon-like and sort of with a desperate quality about it, taking on the identities of those around them or groups in which they would like very much to fit in. The next symptom is impulsivity, which I'm sure many of us have seen, and this needs to take place in at least two areas that are self-damaging or making things worse. And those could include any number of things: substance abuse, very common, eating disorders, overspending, very want-driven behavior, promiscuous sexual activity, any of a number of those impulsive behaviors that are very perplexing to family members. The next symptom is recurrent suicidal behavior, gestures or threats, or self-mutilating behavior. And those of you who have experienced this, it's very traumatic. It's very difficult to deal with and difficult to understand. It's hard to comprehend that someone would feel that there is such a lack of hope, that there's no other solution. Next slide. Number 6 is an affective instability, which means that there's a very noticeable reactivity of mood. And that can change extremely rapidly in a matter of minutes. You may have experienced a lot of irritability, anxiety, or a feeling of intense dysphoria or mental unease or unwellness. That typically doesn't last for a very long time. So it may last for an hour or so, and often not more than a few days. Number 7 is chronic feelings of emptiness. And I think unless you have experienced this, it's difficult to understand this. Some people with BPD have described it as a feeling of that there's nothing from here to in their torso, just nothing there. Other people have related it more to intense feelings of loneliness and respond to that descriptor as opposed to emptiness. And still, we can imagine it's a very that feeling would create a lot of suffering. And number 8, so this is something that family members experience very commonly, and what seems to us to be an inappropriate, extremely intense anger and difficulty controlling that anger. So an anger that can escalate so quickly that sometimes it leads to destruction of property or physical violence. And the last, number 9, is transient stress-related paranoid ideation or dissociative symptoms. And paranoia is not seen as commonly. However, I can give you an example of what, a small example of what dissociation might feel like. So most of us have driven home from work and we are daydreaming or thinking about something entirely unrelated to driving, and maybe we suddenly look out and we realize we've passed the exit for our home where we were going, and we have we are essentially waking up and have to turn around and go back. So in that moment, we are driving, but we are not really there. We're not really present in what we're doing in the moment, but we are in fact somewhere else, not based in that reality. So that is might give you a small idea about what dissociation might feel like. Next slide. So Marcia Linehan has grouped these areas of dysregulation into 5 categories, and they can be thought of as dysregulation of behavior, interpersonal dysregulation or dysregulation in our relationships, self-dysregulation, or that unstable sense of self, and cognitive dysregulation, which involves thinking and being able to make effective decisions for yourself. So I want to talk next about emotion dysregulation, which is something that we see sort of the causes and consequences of rage and anxiety and depression. Next slide, please. So if you look at this, I like this diagram. If you look at this, you can see that emotion dysregulation is in the center, and sort of all those things that are occurring on the outside are sort of you could think of them as the detritus of emotion dysregulation, or essentially each of those things are the cause or consequence of emotion dysregulation. But before we go any further, I want to talk about what is emotion dysregulation? What does that mean? And emotion dysregulation is definitely not being upset. So to equate it with being upset is not going to be helpful in leading you to be effective. So I want you to think about a time, and everyone has had this happen to them, when your emotions have been completely out of control. So you have felt such intense emotion that you've not been able to make a decision. You've not been an effective decision. You've not been able to control your behavior. Those out of control emotions are emotion dysregulation. And it's really important to understand that, so that you're not thinking that this is something that can easily be turned on and off or easily controlled by our loved one, because it's not, as much as they would like to. So let's take a look at this. If you see those arrows going out, those could go both ways. Those are, in fact, reciprocal, leading to and from emotion dysregulation. So obviously we have problems in relationships with out of control emotions, anxiety about emotion dysregulation, about it happening again, anticipatory anxiety of it. We've talked about those fears of abandonment. I really would like to talk about problems in thinking and problem solving. So maybe you have said to your loved one when they have engaged in a behavior that you don't understand, maybe you've said, "What were you thinking?" And the reality is there was no thinking going on. The ability to think was shut off and offline by this high level of emotion dysregulation. So the ability to cognate and the ability to do that is offline. And so what we see then is that often that the desire to get that emotion down is the only focus. It's like feelings are on fire and you want to put that fire out, regardless of consequences. So they're in that moment, they're not thinking about, well, I might end up in jail if I do this, or I may end up losing my job if I do this. None of that is going on. Really important to understand. Lots of self-judgment about this, lots of self-loathing, low self-esteem, thinking that they're a horrible person for some of the things that have occurred, even though that may not be verbalized to you. Impulsive behaviors and attempts to avoid emotion altogether or numb with substances or any number of ways to numb that emotion. Next slide, please. So Marcia Linehan, who is the developer of DBT, speaks about borderline individuals as being the psychological equivalent of third-degree burn patients. So it's as if they have no emotional skin. So even the slightest thing they are feeling. There's one researcher who calls people with borderline personality disorder supersensors. And in my own case, a decade before I knew anything about BPD, my son's first grade teacher, when he was 6 years old, said to me, "It's like he has no skin." And at that time, I had no inkling of what was to come. Next slide, please. John Gunderson, also who was at McLean, and considered to be was considered to be the father of borderline personality disorder. Talks about the interpersonal dysfunction of borderline personality disorder as the best discriminator for the diagnosis. So it's those relational problems that really cause difficulty and let us know that a person is suffering with this illness. Next slide. So just some basic facts about borderline personality disorder. It appears to affect anywhere between 2 and 6% of the population. That's a lot of people, more common than you might think. That number actually equals or exceeds the number of people diagnosed with bipolar disorder or schizophrenia. This piece about 75% of patients are women we now know is misleading, and we think that really it's more like 50-50 or close to 50-50 of people different genders who are affected with borderline personality disorder. What happens is that more women tend to seek treatment, and sometimes what happens is that men may not, and they may act in ways that get them diagnosed with antisocial personality disorder or get them in trouble with the legal system, and as opposed to entering the route of effective treatment. So one of the most confusing things about borderline personality disorder for families and also for some clinicians is that it presents in lots of different ways with well over 200 combinations of different symptoms. So it's not as if there is one presentation. It's that it takes a lot of expertise to be able to come up with an accurate diagnosis. And family members may see lots of different behaviors that aren't easy to put in some of the categories we're talking about. Next slide. So just to give you an idea about funding and research and what's happened over the past couple of decades is that you can see how common borderline personality disorder is relative to bipolar and schizophrenia. And at the same time, you'll see how much funding and money was put into research by NIMH for schizophrenia and bipolar disorder compared to borderline personality disorder. So we have been thought of sometimes as the orphan diagnosis, and NEABPD is working hard to raise awareness for borderline personality disorder. So in essence, we're about 20 years behind resources and research for borderline personality disorder compared to some of these other less common disorders. Next slide. And at the same time, the dialectic is that things are slowly improving. So NIMH is more focused on funding translational research now, which means research that can be connected to treatment and vice versa more directly. In April 2008, we have done, at NEABPD, we've done some congressional briefings leading to May being declared as Borderline Personality Disorder Awareness Month. And all over the world, as Abby mentioned, at NEABPD, we host conferences and educational seminars for professionals, inclusive of family members and also clients, all as a functioning to help raise awareness and education for borderline personality disorder. Next slide. So shifting gears just a little bit, let's talk about some of the different possible treatment settings that you may have encountered for borderline personality disorder. Now, ideally, an individual with this illness would be placed in the least restrictive setting that would be possible and helpful for treatment. So in this list, you see number one, starting with the most restrictive setting, which would be inpatient treatment in a psychiatric hospital, possibly even in a lockdown unit. It's highly restrictive and hopefully would be used only in emergency situations, true emergency situations for short periods of time. The next most restrictive setting would be a residential program. So that would be a program where an individual would go and live there, and they would receive treatment. Also a highly structured setting. So there's not a lot of independence that is expected there. The next level of hospitalization, which isn't as common these days for insurance reasons, would be a partial hospitalization or IOP, which would be intensive outpatient. So what that means is that perhaps the individual would go during the day to this hospital or setting, and maybe from 9 to 3, like school, and possibly learn skills or receive treatment of some type. And then they would leave that setting and sleep elsewhere in the evening. So that's less restrictive. And the last setting, which is the most common and probably the one that you're most familiar with, is outpatient treatment, or treatment as usual. And that is often in a community setting. It may be that an individual goes to see a therapist in their community once a week or twice a week, and the rest of the time they're outside of that setting. So that's obviously less structured and less restrictive. One point I want to make about this is that you may have experienced, as I did, is that the junctions between these different settings are very vulnerable, very vulnerable for the individual who has BPD. So if someone is doing extremely well, say in a residential setting that is very structured, and they are feeling very confident, and then they are taken out of that setting and perhaps put back in their home or put back in their regular school setting. Oftentimes that's a very difficult and abrupt change for individuals, and they may not do well. Ideally, there would be wraparound care, meaning that at these junctures there would be step-down treatment, so that individuals could have individual additional help to integrate back into their homes and schools and work. And we all know that with our healthcare system that this often does not happen. Next slide, please. So in terms of BPD specific medication, there is no pill that we can say is a BPD specific medication. So there is no medication for BPD per se. Most of us have experienced the fact that some of the co-occurring conditions may be medicated and may be heavily medicated. So depression and anxiety, those co-occurring conditions may be treated with medication. And sometimes there's not a lot of oversight in this, in that medication. Next slide. So in terms of, we talked a little bit about those different, treatment settings, but different types of treatments that might be helpful for borderline personality disorder, and a way for you to think about how you might seek out treatment if possible. So we do know that treatment is as usual, which could be described as traditional talk therapy, where the individual might go into their therapist, talk about what happened last week, talk about what's going to happen this week, just in general, trying to discuss, things that are going on in life. That is not good enough treatment for borderline personality disorder. So BPD requires very, in general, specific therapies that we know to be effective. So you could think about that treatment as usual, kind of like a massage for a broken leg. It may feel good at the moment and maybe shortly thereafter, and yet it's not solving the core problems or giving a person skills to cope with those issues they're facing. Next slide, please. So I'm going to talk a little bit about the different types of treatments that we do know that are efficacious for treating borderline personality disorder. Not in all cases, but in a significant number of cases. So DBT is dialectical behavior therapy, and it was developed by Marsha Linehan, who in Washington State, who herself suffered greatly as a young person from borderline personality disorder. So DBT at this time has well over 30 controlled studies, all with positive results. So that's the kind of data we want to see when we're seeking out a treatment method. So DBT centers around dialectics, and dialectics are essentially a worldview, something that we'd like to help you incorporate into your worldview, that holds that opposites exist all the time simultaneously in the world, and that there isn't any one absolute truth, and that two things that appear to be very opposite can both be true at the same time. So for instance, I can be very angry at a family member, and I still love them at the same time. In DBT, dialectics center around acceptance skills like validation, which you'll learn about later. So accepting who you are and what's going on in your life, and what is happening in the here and now, accepting that. And at the same time, continuously working on change and problem solving. So it's a balance between acceptance and change. And that is the approach that Marcia Linehan found to be most effective in working with people who have borderline personality disorder. And without that acceptance piece, continuously focusing on change, she found to be not effective. So in DBT, the therapist and the client are working together as equals, working on reaching a synthesis of these opposing forces, and always working towards goals of a life worth living. So that life worth living is a life worth living for the person with borderline personality disorder. So it's their goals, not our goals for them, but their own goals that they need to be working towards. Next slide, please. So DBT there's DBT and then there's DBT. So someone who is intensively trained in DBT would be a top choice for someone with borderline personality disorder. That means that they have intensive training of 10 days over a 6-month period, and they are supervised. It's DBT in general is a highly manualized treatment, so there is a manual that Marcia created. And in DBT, therapist and client are always working on a hierarchy of targets, starting with things like suicidality and self-injury, and then therapy and interfering behaviors, and then working ultimately towards goals and a life worth living, and including joy in that. It's a modularized treatment, so there is distress tolerance as a module, core mindfulness, emotion regulation, and interpersonal skills. So in Family Connections, we are also taking from this and teaching sort of mini DBT skills. So you can see in the diagram that there's always a balance and working back and forth between acceptance of what is and also trying to change what is. In DBT, about 2/3 of patients do well, and about 1/3 do not. So there are other types of treatments available that we know are efficacious for borderline personality disorder. Next slide. So another type of treatment, and I do understand, you know, that not everyone can access these treatments. They tend to be in big centers, in big urban centers, DBT and mentalization. So I do understand it's not easy to access these comprehensive DBT programs all of the time. Mentalization was developed in Great Britain by Anthony Bateman and Peter Fonagy. They also have data showing its efficacy. So as we talked about before, the aim is for people to learn more about how errors in their thinking, both about themselves and what others might be thinking, lead them to behaviors that might not be helpful for them. So in a nutshell, it could be thought of as learning to see yourself from the outside in and learning to see others from the inside out. And that, if you think of it in that way, it's a way to understand what mentalization might be. Next slide, please. So before I talk a little bit about how do you choose a treatment, there's one other treatment that I'd like to mention that's called GPM, which is General or Good Psychiatric Management. And this is a newer treatment that is developing a database and an evidence base, and it was developed by John Gunderson at McLean. And because there is an understanding that it's difficult to access full DBT comprehensive programs and mentalization programs, now therapists from McLean are training people in this method of general psychiatric management, or good enough psychiatric management, so that it helps to fill that gap. So it might be possible to find that in your area, and it revolves around good case management for individuals with borderline personality disorder. Next slide. Oh no, let's stay with this one for a minute. So I can see also that I'm running out of time, very much. So I'm going to go a little more quickly. We're almost done. How do you choose a treatment? You look for data in peer-reviewed journals that this treatment is effective. Any specific borderline personality disorder treatment is probably going to be better than treatment as usual. Ideally, it would be nice if the therapist has experience with including families in that alliance around an individual. That's not always the case and easy to find. Next slide, please. Okay, and finally, the last thing I want to talk about is just that the fact that BPD rarely stands alone, and that there are co-occurring problems that we see and that make this disorder, like I said, extremely confusing. And these are some of them: anxiety, depression, substance abuse, eating disorders, and other personality disorders. All can exist along with BPD. And the last slide. And likewise, the presence of another diagnosis does not preclude borderline personality disorder. So if you're diagnosed with depression or anorexia or bulimia, that doesn't mean that you do not could also have borderline personality disorder. And these are examples of some of that. So I know I covered a lot of material in a very short time, and we have a few minutes left. I'd like to take any questions that you might have.
So before we open up for questions, I just want to thank you so much, Beth. I'm going to give you 3 quotes that have come through from people listening today. This is the best primer on BPD I've ever heard. One of our board members who's listening texted me and said, Beth is a rock star. This is an incredible presentation. And I have another quote here saying, your analogies have been so eye-opening. Thank you so much. And there are definitely more coming in, I'm seeing through the chat. So I just want to thank you. We will open it up in a minute for questions, but I want to let everybody know that, as I mentioned earlier, we are a nonprofit organization, and we are able to do events like this and Family Connections for free because we have so much generous support from our community with donations. There is a website below, and if you have the ability, we would appreciate you supporting us in any way you can. We love our volunteers, we love our donors, and we're only able to thrive and be successful because of them. So I'm gonna, I have a couple of questions here that I'll open it up. The first one, you talked about recovery. Can you define recovery?
Yes, that's an excellent question. So in most cases, recovery is defined as dropping out or no longer meeting criteria for borderline personality disorder. So that means that a person no longer has 5 of those criteria we talked about for borderline personality disorder. So as I said before, if someone only has even 1 or 2 of those criteria, their lives can still be extremely chaotic, as can be their relationships and family life. So it's important to understand that someone might be no longer self-harming or no longer maybe suicidal, and yet they can still be struggling immensely.
Okay, we have a couple of questions about some online counseling. Is online counseling helpful for BPD? And then someone else asked, because of the current situation, is there any research on deploying DBT remotely?
So I am probably not the best person to ask about data related to that. I know that there are lots of therapists now who are in fact working online because they can't work face to face. And Zoom, just speaking for myself, working with families, which is what I do, Zoom has been very effective, a very effective way to reach people. And there are some online DBT self-help websites. I just would, caution someone to perhaps look on our website, which has vetted information for you.
We have a question here. What kind of help do you suggest for parents of someone who had BPD?
So number one, it would be sign up for Family Connections immediately. I honestly, I think that is what, the best starting point and the best way to learn to get into a class. And then also donate to us so that we can do more.
I'm looking through here, the questions. We have a lot of questions here asking, should someone with BPD live alone or live with me? Types of things like that. And I'm not sure we can answer that without knowing the
Yes. Yeah, it's really difficult. All I can say, that brings up a point that Perry Hoffman, who, was the president of NEABPD and recently passed away, she used to say, if someone was on a deserted island, then there would be no BPD for them. And what that means is that, without that friction of the relational aspect of borderline personality disorder, we might not see some of those symptoms so readily. So obviously that's not always possible, and yet we can see that living with someone for all of us creates friction, particularly now.
Is BPD genetic or environmentally caused?
So in later following webinars, you're gonna hear that we have something called the biosocial model that takes into consideration inherent vulnerabilities, biologic vulnerabilities, as well as certain environments that can lead to the development of the disorder. So it's both, essentially.
We also have a couple of questions here. You had mentioned a third type of treatment that John Gunderson created, and I know we didn't have a slide about it, and people are asking for the name of it and how to find it.
It's called GPM. So GPM, which is General or Good Psychiatric Management. And like I said, it does come from Harvard, from McLean. And so that's the source of it. And now teams of trainers are going out to train psychiatrists in different geographic regions to use GPM.
We also have a bunch of questions about, can you give me a reference for a good therapist, a good residential treatment center?
No, I'm sorry. That's not. I mean, I think what we are trying to do here is to tell you what might be the most helpful treatment that you can access, and then you do have to buyer beware. You do have to do your own research to figure out in your area what's available. Sadly.
What do you do with a person who refuses to, you feel that they have BPD, but they refuse to?
Right. I have a lot of experience with that. And I would say that, using these skills, again, in Family Connection, some of the skills that are going to follow in webinars are going to be your best bet. Constantly remaining polarized in your family, in other words, saying you do have it, you will go to treatment, and they're saying I won't and I don't, is very ineffective and not helpful. And so you have to find a way to meet in a validating way and be effective. And you will be able to learn skills to start to do that. But hammering away at it that way is not effective, for sure.
So I think we are at 5 o'clock, and I do want to thank you, Beth, so much for providing us this information. This webinar will be posted on our website within 48 hours for you to access again or to share with a family member or a friend. I will go through all of the questions and all of the chat questions in the next 24 hours. And if we are able to answer them, I will provide you with an answer or a link to something on our website that will answer the question for you. I'm sorry that I think we have over 120 questions here, so we weren't able to get to them all. But we are going to be continuing doing future webinars. We know that this has been very successful over the past 2 days. We have one scheduled for tomorrow, and there will be another email going out tomorrow with additional webinars following up for the rest of the week and into the next few weeks. We will be addressing all of the skills learned in family connections, radical acceptance, validation, self-validation, mindfulness, relationship mindfulness. So please be patient with us, and we thank you so much for joining us today, and we look forward to providing you more information as time progresses and being a resource to you. Thank you.
Thank you. Stay safe, everyone.